Welcome to UOA On Demand. I'm Ryan Coyle. I'm an orthopedic surgeon and hand and upper extremity specialist with UOA. And tonight we're going to be discussing Dupuytren's contracture, Dupuytren's disease. Here with us, we have Dr. James Monica and Dr. Timothy Leddy. If Dr. Monica, if you maybe want to introduce yourself.
Sure. Hi, my name is Dr. Monica. It's a pleasure to be here talking about Dupuytren's contracture. I'm a hand and upper extremity specialist at UOA.
And Dr. Leddy?
Hi, Tim Leddy, also hand upper extremity trained. We look forward to talking about some Dupuytren's tonight.
So Dr. Monica, what is Dupuytren's disease?
So Dupuytren's disease affects primarily the hand and the palm, and it's a disease that causes the tissues underneath the skin to change and form almost like a scar type appearance or texture underneath the skin, and usually happens and involves the ring or the pinky finger, but it can involve the other fingers. And sometimes the scarring can get so bad it can contract the fingers, and the fingers can start to bend. And when that happens, it can affect function. So there are several treatments to help that, but it's usually a slow progressive disorder, usually genetic in origin. We see it typically in Northern European descent. And so it does run in families.
So Dr. Leddy, is Dupuytren's painful? How do I know that I might have Dupuytren's, or what would be some concerning signs?
That's a good question. I mean, in general, Dupuytren's is not painful. When the nodules in the palm first show up, and they can be sort of in this skin crease right here, they almost seem like calluses. And when they first show up, they can occasionally be painful. And in rare cases, I will inject one of those just to sort of quiet that down. But as a general rule, those can be left alone. When they first pop up and they're not creating any contractures, that's a short-lived period of time where they're uncomfortable. But as a general rule, Dupuytren's is not painful.
So we know Dupuytren's isn't painful, and we know that it tends to affect people that are lighter skinned from northern areas for various genetic reasons. And we also know that there are certain risk factors, such as alcohol use, smoking, and these are not necessarily, there's no guarantee that anybody who uses alcohol is going to get Dupuytren's, but these are things that have been shown to be associated with it. Dr. Monica, so if you notice a nodule in your palm and you're concerned that it's Dupuytren's, what are some things you can do, and who might a patient benefit from seeing if they have a problem like this?
So you could just Google it, and that may give you the answer. No, just kidding. So one of the things I would do is, I would try to maybe first see my primary care doctor. Maybe they'll have an idea about whether or not it's a Dupuytren's nodule versus other things, like it could be a cyst. It could be just some callus formation. So maybe just starting with my primary care doctor, and then but if I had further questions after that, then seeing a hand specialist would be a good idea.
Right. I think that hand, as a hand specialist, and we see a good amount of this. It's probably not the most common condition to come into the office, but it is common, and patients are often, if there is no family history of it, sometimes they're not sure what's going on, and can be concerning. If you see a lump in the palm or the hand, it's a little bit strange, and especially if there's any sort of change in function. What are some physical problems that people might have, Dr. Leddy, if they have Dupuytren's contracture? What are some functional things that they might struggle with?
And I want to touch on one thing beforehand that you both sort of referenced. One is Google, and a lot of people will Google this and get some bad information. And two, that bad information comes in a variety of different forms. And you had mentioned one, that alcoholism can be attributed to this. And that's actually been debunked. And that was researched in the 1950s, when people were being studied in in Northern Europe of all places, right? So they were trying to figure out the etiology of this, and they wanted to study people over long periods of time because, as many people now know, Dupuytren's doesn't happen until you're frequently in your 5th or 6th decade of life. And so why is that? And what is the etiology of that? And so they studied people that were in sanitariums, and they don't exist anymore, but that was a captured population of people that were in sanitariums, not because of Dupuytren's disease, but because of things like schizophrenia and epilepsy and alcoholism. And they made some sort of inappropriate correlations back in those days about those things. Interestingly enough, though, the basic science has bred out that, there may have something to do with the oxygen tension curve and how well people are able to distribute oxygen through their circulation. In other words, from the lungs to the blood and then into the soft tissues. And that may be one of the things that's triggering this gene to turn on at a later age in life, because we know that oxygen tension curve moves to the left as you get older. We also know it moves that way if you're a smoker or if you're a diabetic or if you have some of these other potential comorbidities. We also know that the drugs that they use to treat epilepsy can make those kinds of changes too. too. So there may be other reasons why those correlations were made, but I think you got to be careful with what you read. I think Dr. Monica makes a good point. Stay off the internet. Don't Google your things and trying to figure out what's going on. Suffice to say, I think the most common thing that I have with people complaining is they can't shake a hand, or they can't put a hand in a pocket. They have trouble grasping things without kicking it away because the fingers are already bent. And when they go to grab something, they just knock it out of their fingertips before they're able to close their hand around it. So it is a pretty significant functional problem when the fingers get to be about 30 or 40 degrees contracted, either at the PIP joints or at the MP joints. And in many cases, you guys know, it's both.
One of the chief complaints my patients will have is I can't get my hand flat on a surface. I can't get my hand in my pants. Usually when the patient can get their hand in the pants, it's a more advanced case of the problem. But these are, the tabletop test is one of the classic diagnostic findings where the patient can't get their hand on the table. And there's a commercial on TV right now where everybody's trying to put their hand on the table and no one can do it. There are certain treatments out there that are being heavily marketed to the population. Before we talk about invasive treatment, Dr. Monica, would you say there are any sort of non-invasive modalities out there that patients can think about doing? If somebody comes in and say, I have a nodule in my palm, it's a little sore, but it's not really bothering me that much, and I'm not functionally limited. Is there anything that I can do to minimize the chance it might progress in the future?
I'm not sure if there's anything you could do to minimize the progression, but one thing that I will offer that patient is if they are annoyed by the nodule is an injection of triamcinolone, which is a steroid, and that's been shown to maybe soften the nodule a little bit, maybe have it decrease in size just a little bit. But I'm not really I don't tell them that I'm doing this to prevent further progression. One other thing that I would mention is that I think progression is correlated with trauma.
One thing I think that's 100% true is that patients who are getting repetitive impact in the hand, heavy laborers, those are people that we tend to see this condition get worse pretty quickly in. Another population that you have to be aware of is if somebody has a Dupuytren's lump or nodule that's not that bothersome, if they need any sort of other surgical procedure, not for their Dupuytren's, for example, a trigger finger, whether or not it's in direct proximity to that lump, that's a patient that really needs to be aware that your Dupuytren's could worsen, and whether or not you take that nodule out at the same time, it still can flare up and be bothersome. Dr. Leddy, what would you say is a Dupuytren's flare, and how is that something that might be treated?
I mean, I would treat that very similar to what Dr. Monica was just saying. A little injection with some lidocaine and a mild steroid can frequently quiet that down. I do not like to use oral steroids. There's nothing wrong with giving a trial of some regular over-the-counter anti-inflammatories. Again, that tends to be a self-limited thing. So my best answer for that is leave it alone. It'll settle down. One of the caveats you have to consider, though, is that if somebody shows up with a nodule in their palm, it might not be Dupuytren's disease. It might just be nodular palmar fasciitis, and that's a reactive thing that can happen after somebody's been casted for a while. The pressure of a cast in that area can frequently result in some thickening, not just of the skin, but the fascia below, and that tends to be transient. So watching those, I think, is the right answer. You referenced that palm flat rule that we use, and I think that that's a good rule of thumb for patients to understand and learn, that they really don't need to do anything treatment-wise until they can't get their palm flat on the table. And even then, it may be too soon, but that's when we like to start tracking them a little bit more closely.
Yeah, that's definitely true. Unfortunately, our all of our conservative treatment options, such as stretching, hand therapy, home exercises, we don't really have a lot of good evidence that they will support or minimize the chance that this will get worse. And we don't want to waste patients' time. So that's something that I frequently won't, I'll discuss with them and explain that this is unlikely to help you in the future, because at the end of the day, we don't want to send our patients to do interventions that aren't going to help. So a patient has a contracture that's bad enough that it's impacting their daily life. Dr. Monica, what are some treatment options that you might discuss with the patient that are more invasive than an injection?
So there are a couple options out there. One involves it's called percutaneous needle aponeurotomy, and that's just a fancy word for kind of putting a needle in and out of the skin where the contracture is the worst. And the goal is to try to break up the contracture or the cord that's formed there to give them some more motion, to extend the finger basically more. And that's a procedure that can be done in a surgery center. It could even be done in the office. I typically don't recommend that procedure often, just because I think it has a higher recurrence rate than surgery. But that's a minimally invasive procedure. That's an option. And there's another one that involves injecting an enzyme that can break up some of the Dupuytren's cord as well. And for similar reasons, I'm also not that big of a fan of that procedure as well. I have done that in the past and just kind of had mixed results compared to surgery, which involves, there's different invasive levels of surgery where you could take out just the diseased tissue, you could take out the diseased tissue plus some of the normal tissue around it, or you could also take away the skin as well. So there's a whole gradient of surgery as well, but I tend to do the, just remove the diseased tissue.
Yeah, certainly there have been a lot of different treatment options and degrees of intervention that have been researched and published about. Dr. Leddy, what are your preferences in terms of being more invasive and removing as much as possible, and or being minimally invasive? How do you like to counsel a patient?
Well, I like Jamie have had not great experience with the collagenase injection, the enzyme to break the tissues down. I find that to be a very blunt instrument. And collagenase is, just like it sounds, collagen breakdown enzyme, essentially. And everything in the finger and in the hand is collagen, so it's not necessarily a very specific thing. Now, you can specifically put it somewhere with where you're guiding the needle, but once it goes into the hand, it does kind of what it wants to do. And my experience has more to do with taking care of people that have had collagenase really elsewhere and been referred in. And it makes it much more difficult, in my opinion, to manage that surgically when it comes to that. So as a general rule, I don't use a lot of collagenase. I also don't like the needle aponeurotomy. I think it's a clever technique, but it's, simply poking holes over and over again in a somewhat random pattern until the cord breaks never really made a whole lot of sense to me. So if I'm going to do a percutaneous cordotomy, I'm going to do it with a blade, and I'm going to do a very specific cordotomy with the tip of a very sharp blade so I know exactly where it is. And it has to be in the right selected patients. Not every patient can have that. I don't offer that for patients that have a PIP joint contracture, but I will offer it to an MP joint contracture. And in the right selected patient, that can buy them a lot of time. But to Dr. Monica's point, that tends to be temporary. Recurrence rates are not insignificant. Then typically the next step is going to be more of an excision of that diseased tissue. Whether you do it, from the palm through the finger, or you do a more significant fasciectomy, I think there's still an argument there. I've always been in the camp of doing a fasciectomy of the part of the tissue that's diseased and leaving the other tissues alone. So if there's disease just in the ring finger or the ring and small, those are the two areas that I'm going to address, and I'm going to leave the rest of the hand alone. And if they develop a contracture later in an index finger or in a web space, then I would deal with that separately as it comes up, but not prophylactically remove that tissue.
So we know that there are different risks of recurrence, and whether that's defined as recurrence of any contracture or recurrence of a contracture needing another intervention, we know that that has a significant variability based upon the treatment type. And unfortunately, the collagenase has really been shown to be one of the most prone to recurrence and needing further intervention. And like Dr. Leddy mentioned, the collagenase is a pretty blunt instrument, and that can cause a lot of scarring and make it difficult for the surgeon who's going back in to identify other structures that you don't want to cut, because this diseased fascia can wind its way around other structures like nerves and blood vessels and tendons that you don't want to cut and you want to leave intact. Dr. Monaco, what are some risks of surgery that you might counsel a patient to be aware of going into a more invasive procedure?
Yeah, that's a really important question that I try to be pretty thorough with answering every time a patient is considering surgery. And we talked about recurrence. Recurrence is certainly a risk even with surgery. Tough to nail down an exact percentage. It's really different by each case, but recurrence is certainly up there as a risk. Nerve injury, as you mentioned, this tissue does tend to intertwine with the nerves of the finger that you're operating on. And that means that if you do have a nerve injury, it's not that you're going to be able to lose motion at all, but you'll lose sensation, and it may be on one side of the finger or the other side, or sometimes both. Not too common, but it certainly can occur. You may have some tingling after the surgery that lasts for a little while, but then the sensation does improve, or you could have no sensation. So that's an important risk to discuss. And then lastly, just some skin healing problems can happen where it takes a while for the skin to heal. We take out a lot of tissue. Sometimes we even take out a little bit of skin that seems to be very close to the diseased tissue. And that may take time to heal, and sometimes some collection of blood can form also underneath the skin that can cause issues, and that needs to be dealt with. So there's wound healing complications, nerve injury, recurrence are the main ones that I talk about.
Yeah, I'll always counsel my patients, especially those where the tissue involves the finger and not just the palm, that there's a real risk of the patient's going to wake up and they're going to be numb, especially if there's a significant PIP contracture. Because I think the worst thing that can happen is a patient is not expecting a complication and they wake up and they have one, even if it's something that's going to resolve. I think that unfortunately, injury to the digital nerve, whether it's a stretch or a laceration, it's a known risk factor, and presence of the tissue in the finger, contracture of the PIP joint, the first joint of the digit itself, is really it's a known risk, and the patients have to be aware that these things can happen. And more so than just recurrence of the disease, people that have a really stiff bent PIP joint, that can recur or fail to be improved regardless of whether the Dupuytren's tissue is removed or not. So you may be able to get the finger straight in the operating room. You may be able to take a picture of it, and then 6 weeks, 8 weeks, 12 weeks later, in the face of hand therapy, the patient may come back and they may still have a bent finger that won't extend all the way. So these are things that no one has been able to completely get rid of the risk in treatment of this disease. And people need to be aware that it's a bad problem. And if it's a bad preoperative problem, you can't always expect a perfect outcome later on. Dr. Leddy, any thoughts about how you counsel patients preoperatively about expectations?
Yeah, I think neuropraxia, which is, the tingling that people get in the finger, is standard. Like I tell them right up front, they're going to get some pins and needles because we're going to be retracting the nerve, and the nerve doesn't like that, period. So very rarely do people have absolutely normal sensation. Rarely. It's more common that they have some dysesthesias or pins and needles and funny feelings that will go away. And to be clear, there are those temporary dysesthesias after surgery, and then there's anesthesia if the nerve has been lacerated, whether it's, regardless of the mechanism of that. But we, as a general rule, will repair that on the way out. So it's not like that nerve is a foregone conclusion. To Dr. Monica's point, they may not ever get all of that sensation back, but the expectation is that if we've damaged a nerve, particularly in revision surgery, so the second time around, very easy to damage a nerve, we would repair it and then we'll get some protective sensation and some sensation back. So it's not necessarily an absolute loss. But I do counsel them pretty strongly and differently depending upon whether it's a primary or a revision case because of that. It's not uncommon if somebody has a more significant contracture that we cannot close the skin and we'll purposely leave it open, particularly in the palm, or leave little gaps behind. And again, that's going to be a delayed time to wound healing. Those patients I typically send to hand therapy so they can get some wound care with the assistance of the hand therapist in addition to getting the fingers moving. And I really think the hand therapy is a critical part of getting maximum benefit and maximum motion out of the finger. And I quite honestly cannot tell you why one patient can come in and they're little tiny scars and their fingers are nice and straight, and the other patient with practically the same operation after working in hand therapy and everything else, they do have a little bit of a recurrence and they can't get that last little bit straight, and their wound is a little bit more lumpy and bumpy. That's just differentiation between people and how they heal. And I don't think that there's any test that we can use to figure out what group somebody's going to be in. So I can't predict for somebody preoperatively what kind of scarring they're going to have afterwards. And I think I wouldn't necessarily call that a risk factor, but that's something that it's worth having that conversation, because to your point earlier, you say you have a patient that comes in and they're not quite all the way straight. They're going to have questions about that. And if you've had that discussion beforehand, that they realize that that's a potential, that they're going to have better motion, but it may not be full motion, well, then they've had their expectations set appropriately. And anybody that gets 100% of their motion can just realize that that's really a great outcome, and that's not always the way it is.
I agree completely with that. I would say one other thing I would mention is that I do think overall and I think we kind of touched on this, that the risk increases with the amount of contracture. So, our indications for surgery are, and this is in a textbook, where if you have a contracture at this joint here, this row of joints that's 30 degrees, then that's something that we consider operating on. And then I think, Ryan, you may have mentioned it before, if any contracture at this joint, which is the next one up, we can recommend surgery for. So I would say the earlier the patients could get in when they're, getting close to that level of contracture, makes our job easier. I think makes the surgery probably more successful in the sense that it's less risky.
I think that's very important, and it's a good reason why a patient, will benefit from a hand surgery or upper extremity surgery consultation, at least to just get a better understanding of what's going on. Because I do see many patients, and I'm sure we all see many patients who come in and they have been, they do a tough job. Their heads have been beaten up for years, and they have a 60-degree PIP contracture, 30, 40-degree MP contracture or worse, and they have significant disability, but they've just adapted and accommodated. And those are the patients, unfortunately, for whom surgery has significant risks, as opposed to the patient, like you mentioned, with a 30-degree isolated pretendinous cord, MP contracture, which the complication rate is going to be a lot lower. So, getting in early, understanding what the risks of surgery are and the risks of waiting, I think can really benefit a patient, because surgery has risks, but different types of surgery have different risks, and surgery on a really bent finger is a real minefield compared to some of the less invasive or less challenging cords we see.
Yeah, there are a few things in orthopedics where you can potentially burn a bridge. I mean, you can live with a lot of different types of aches and pains, but if you let a contracture go too far, too long, you can really burn a bridge and make it much more difficult for, the primary surgery to remove that tissue. And it sometimes, we have to dig deeper into our toolbox. Dynamic external fixation is something that I didn't have when I was originally coming up in training, and we have now to try and crank a finger out at least a little bit straighter and potentially make that operation a little bit safer. Because if a finger is down, curled into the palm, that's very difficult to manage, primarily surgically. And the risk to the finger is much, much higher. You can lose a finger. That's part of what needs to be discussed with patients, is that that's not unheard of. Now, it's incredibly rare, thank goodness, but it's not unheard of.
Yeah, that's absolutely true. In patients with severe Dupuytren's contracture, especially if it's multiply recurrent, amputation is an option. That's extremely rare and hardly ever something you discuss with the patient the first time around, but it does happen. And the more the deformity, the more you're asking out of your blood vessels and nerves to accommodate a large correction. And so that's something that realistic goals have to be discussed. Fortunately, that patient is very rare, and most of the time people come in before that, but that just heightens the importance of early recognition and early understanding of what your problem is.
I think patients should understand that it's not a very rapid thing. As much as we're saying you've got to get in early, we've got to check on you and everything, it's not like a contracture is going to happen overnight. This is the kind of thing that evolves over from going from straight to here could take years, literally years. But to go from here to here can take months. And I think that's partly why that palm flat rule is an important one to follow, because as soon as they hit that spot where they can't really touch the palm to the tabletop, the flat part of their palm, that's when things start to accelerate. Now, again, it doesn't go very fast, but it's fast enough where they ought to be on somebody's radar screen to make good decisions with them so that they don't end up delaying farther and longer than they should and making it more difficult than it ought to be. So as much as it's something we want them to get in, we don't need to make it an emergency.
So in summary, Dupuytren's contracture is it's a problem that can cause significant functional impairment in patients, and it's something that is a common but not too common problem in the upper extremity, and it's something that we at University Orthopaedic Associates are happy to see you for, happy to take care of, and happy to explain all your questions. Please visit UOANJ.com for more information about our practice and to schedule an appointment if you'd like to come in and see us. Thank you so much to Dr. Leddy and Dr. Monica for joining us tonight, and look forward to seeing you soon.